Good morning. It's an honor and a privilege to have been invited to address you here in this wonderful country, in this beautiful city. I'm going to be talking about a study with the acronym of START in English, Starting Treatment with Agonist Replacement Therapies. And this is a open-label, randomized, controlled trial of methadone compared to buprenorphine naloxone, and Dr. Torrens gave you a very good introduction to those two medications, primarily to look at their effects on liver health, but also to compare them on a number of other outcomes, such as treatment retention, which she mentioned is very important, and also illicit drug use. These are my disclosures. This study was mandated by the U.S. Food and Drug Administration, which is the regulatory body in the United States that makes sure that all approved medications are effective and safe. And because of some preliminary information that suggested that buprenorphine might be harmful to the liver, when the Food and Drug Administration agreed to approve buprenorphine in the United States in 2002, an agreement was made that a post-marketing study would be done to look at the effects of that medication on the liver. And the plan was to compare that to the effects of methadone on the liver because, as Dr. Torrens mentioned, methadone has been used for many decades and was believed not to have any adverse impact on the liver. And some of the secondary intentions were to look at other factors that could contribute to liver dysfunction in these patients. So, to give you some of the background about what the concerns were with harm to the liver, I'll mention this study that was done in the United States, and these were patients who, excuse me one moment. These were patients who were being treated with buprenorphine, and I don't know how the pointer works, but they were divided into patients that had hepatitis, non-hepatitis, and patients who had hepatitis C primarily. And what we're looking at is the median value of alanine aminotransferase, which is an enzyme produced by the liver. And when liver cells undergo injury, this enzyme can be released into the bloodstream, and you can measure it through a simple blood test, which might indicate some liver injury. And what you can see is the patients who were treated with buprenorphine who had underlying hepatitis had an elevation in their alanine aminotransferase level after treatment with buprenorphine. This raised the concern that maybe buprenorphine was related to this problem. In addition, there have been 11 case reports, and these case reports, in fact, came out of France of patients who developed hepatitis while being treated with buprenorphine. And initially, these case reports involved patients who misused the buprenorphine by injecting it rather than taking it by the usual sublingual route, placing it under the tongue as it's supposed to be taken. But there were some subsequent cases where, as far as they could tell, the patients were taking the medication appropriately. And the transaminases, again, are enzymes or proteins produced by the liver that get released into the bloodstream when the liver is injured. And in these patients, they were dramatically increased. All of these patients had hepatitis C as an underlying condition, and all of them actually recovered. None of them died. None of them needed a liver transplant. And some of them, after being taken off of buprenorphine, were restarted on it, didn't seem to develop any more liver problems. So it's a bit of a mystery, which is part of the reason why we did the study. And this is a liver biopsy from one of those patients showing the types of damage that occurred. And Burson et al., working in France, developed a hypothetical mechanism by which buprenorphine could injure the liver because they believe it could be a proton donor in the cellular mitochondria, which is the energy factory for the cell, and that could shut down energy production and ultimately kill the liver cell. Whether this actually occurs or not is uncertain, but that's, again, why we did the study. Here is what we planned to do from the beginning, and part of this was dictated by the Food and Drug Administration. They wanted to see 300 patients on both medications complete at least 24 weeks of treatment. And you heard a little bit in the earlier presentation about the dropout issues, which we'll mention throughout my presentation. So we tested their liver health by blood tests at baseline, and then as you can see, we repeated those liver tests to the extent we could at several intervals, actually 8 intervals throughout the 24 weeks. And we obtained urine toxicology specimens on a weekly basis and a lot of other information that you'll also hear about. That was the plan going in. Here is what actually happened, and I should mention the study was conducted in the US in federally licensed opioid treatment programs. So those are programs where they're all regulated by the federal government, and typically patients come in, especially early in treatment, on a daily basis and take their medication under observation. They don't get any medication to take away until they've been in the program for a while and are very stable. That is the only setting in which methadone can be delivered in the United States. However, it's not the typical setting in which buprenorphine naloxone is delivered. Typically, that is delivered in an office-based setting by a practicing physician, although it's permissible to deliver it in these clinics. The reason we wanted to do it in these clinics is because we're testing the effects on the liver, and we wanted to make sure that the patients were getting the medication on a daily basis. So the best way to do that is to observe them, because in many studies, when the patients take their medication home, they don't necessarily take it as prescribed. So it turned out that we had to screen almost 2,000 patients, and we had to randomize almost 1,300 patients to get our 300 in each condition. And you will see that we ended up with randomizing 740 buprenorphine naloxone compared to 525 methadone. And that is because, as I'll talk about in a few moments, we found that there was a higher dropout rate from buprenorphine naloxone treatment compared to methadone treatment. And in order to get our 300 in the middle of the study, we switched our randomization plan from 1 to 1. You have a 50% chance of getting either medication to 2 to 1. So then you had a 2/3 chance of getting the buprenorphine compared to methadone. We ended up with 340 buprenorphine evaluable, which means they completed 24 weeks and they gave a sufficient number of the liver tests for us to be able to analyze the data, and 391 methadone. Our primary outcome was also dictated by the Food and Drug Administration. They wanted a descriptive outcome with what they called a shift table analysis, looking at the changes in liver enzymes, these chemicals that are released into the bloodstream when the liver is damaged. And I know this looks quite complicated. It's not so complicated, and when I go over the final outcomes, I'll refer to this list again and explain it to you. And in terms of secondary outcomes, we wanted to look at all the things that typically one would believe could affect liver health in these patients. So unsafe use of injection equipment, alcohol use, presence of HIV infection, cigarette smoking, hepatitis B or C as an underlying condition, and illicit drug use. Let me tell you a little bit about the patients who entered the study. They were 2/3 male, which is very typical for these patients in the United States entering treatment in these licensed opioid treatment clinics. Their average age was in their late 30s, and the majority were recent drug injectors. Their Race and ethnicity reflected generally what is seen in the overall United States population, with mostly Caucasians, but some African Americans and some Hispanics, and this is typical, again, of what we see in the opioid treatment programs. Here's some information on their baseline substance use before they entered the study, and this is reflecting their use that they self-report. And we're looking at the percentage of days that they reported using these medications or these drugs in the past 30 days. So the vast majority, since they're coming into treatment for opioid use disorder, did use opioids 80% of the days. They're using cocaine they say about 10 to 11% of the days, alcohol 4 to 5% of the days, benzodiazepines just a small percent of the days, and cannabis also about 10%. This is very typical of the patterns that we see overall for patients coming into these programs. Here we're looking at the urine toxicology drug screens that were done before entry into the study. And naturally, almost all of them were positive for opiates, and as many of you may know, the opiate urine screen does not pick up oxycodone, and so for most of those who were not positive for opiates, they were positive for oxycodone. And you can see many were positive for cocaine, and here is a situation where our randomization failed because the groups were not balanced on their urine tests for cocaine at the outset. The buprenorphine naloxone group had a lower percentage of toxicology specimens positive for cocaine, and we'll come back to that later if we have time. And then you can see the use of cannabis and benzodiazepines. Here's their baseline liver health. About 11 to 12% had abnormal levels of these enzymes at baseline before entering the study. And we actually were surprised at the proportion of people who were positive for active hepatitis C. It's only in the range of 27 to 28%, and previously it had been reported that somewhere between 60 and 80% of patients who are drug injectors entering treatment would have a chronic hepatitis C infection. And the time at which this study was done in the mid-2000s, the epidemiologic evidence does suggest that there was a drop in the rate of new hepatitis C infections, which would suggest that with needle exchanges and more available treatment and more education, we were having an impact on this problem. Unfortunately, the more recent data suggests that, first of all, in the United States, we've had a prescription opioid epidemic for the last 10 years in addition to heroin, but what we're seeing is more of those people who started out using the prescription opioids orally are switching to injecting and switching to using heroin because it's actually more accessible and cheaper. So we're concerned that the rates of hepatitis C are going up again, and actually in the US it can be somewhat difficult in some communities to provide good needle exchange because some people in our country have a puritanical attitude that we shouldn't do anything that might suggest that using needles to self-administer drugs is okay. We're looking now at the dosing of the medications, and we're looking at the average and median highest dose. So you can see that for buprenorphine naloxone, it was well into the therapeutic range that Dr. Torrens described, as well as for methadone, average being 22 buprenorphine per day and 93 for methadone. So these people were getting adequate amounts of medication. And down below, we're looking, because we're giving the medication under observation, now that doesn't mean that the patients necessarily come in every day. They have to choose to come in. But 95% of the expected doses were given in week 1, down to a low of only 83.4% in week 24. And that is very, very good adherence for any study where that has ever been checked. So they are getting the medication. You'll note that there were slightly more total dose years for methadone compared to buprenorphine, so keep that in mind when you evaluate the results here. And here are the main outcomes. So there are 5 basic things that can happen to your liver enzymes, indicating liver damage during the course of a study like this. In the first row, what we have, and we used as our floor 2 times the upper limit of normal. The reason we didn't just use the upper limit of normal is sometimes there can be minor fluctuations that are not too important if someone gets in a small environmental toxin from something in their diet or something else, or maybe they have a binge of alcohol use, they could get a little elevation that would then go back to normal. So we're just raising that to 2 times the upper limit of normal as acceptable. And so you could come in essentially as okay and remain okay for the duration of the study, and you can see close to 80% of the people fit into that category. So that's very good news. We're not seeing a lot of liver injury. The second row are people who came in looking okay, and then their enzymes elevated above 2 times the upper limit of normal during the course of the study. And that's the group we're going to be most interested in. The third thing that could happen is you could come in abnormally high, you could reduce to normal and just stay normal for the rest of the time. And you see that's only a very, very tiny percentage of people in the study. Row 4, you come in above twice the upper limit of normal, and you just stay at that slightly abnormal level for the rest of the study and don't change. And again, that's a very small number of people. And then you could come in abnormal and then get even worse, and that's the 5th row. And that, once again, is a small number of people. So all the major effects we're seeing are people who come in relatively normal. It's about 12 to 17% and become abnormal, and you can see there's no difference between the buprenorphine, naloxone, and methadone. So we conclude essentially that there is no evidence of liver injury from either of these medications. And this just shows that graphically that the 2 medications, red being methadone and the black dashed line being buprenorphine, naloxone, track very carefully as to when people had this elevation during the course of the study. We were able to do a multivariate analysis looking at the predictors of who became abnormal. And among the things that did not predict that change were the medication condition, which medication they were treated with had no bearing, alcohol use, cigarette use, drug use, and sharing injection equipment. The one factor we could find that was predictive of this change was having hepatitis B or hepatitis C. And this makes total sense because we know clinically, especially people who have chronic hepatitis C, tend to have these fluctuations in their liver enzymes, which we don't understand the exact reason for, but they tend to rise spontaneously. So that probably explains the issues that we were seeing. There were 24 participants out of the 1,200 or so who were randomized who had extreme elevations in their liver functions, which would be a real cause for clinical concern. 9 of them in the buprenorphine naloxone, 15 in the methadone. Again, no evidence that medication condition was related to this. And they had enzymes ranging from 10 times normal up to 40 times normal. International normalized ratios, which is a test of blood clotting, and your liver makes the blood clotting factors. So that's a test of the ability of your liver to perform synthetic actions to make biological compounds that it needs to make. And there were a few people who had elevations there, and then a few people had elevations in their bilirubin, which is a test of your liver's ability to conjugate or add on some chemical entities that make a biological substance non-toxic, and a few people had that. So we compared those 24 to 821 who did not have extreme elevations, and but who had enough data available for us to make that comparison. And there was no effect of age, gender, race, ethnicity, unsafe injection practices, hepatitis at baseline or self-reported alcohol use during the study. What we did find is that we tested for hepatitis at baseline, and for those people who were negative and who we could capture at the end of the study, we tested them again. And there were a small number, 9 total seroconversions that we detected, but the proportion among those who had the extreme elevations was much higher. So that, to some extent, it reflects acquiring an acute case of hepatitis B or hepatitis C. And then drug use during the first 8 weeks of the study was more frequently reported among the people who had the higher elevations. So that suggests that it's hepatitis and illicit drug use that is driving these extreme elevations. It's not related to either of the medications that we're using. We're going to move now to some of the secondary outcomes, and the main one I want to address is treatment retention. What you can see here, the open symbols are methadone, and the closed symbols are buprenorphine naloxone. And we had, as I already mentioned, poor retention on buprenorphine naloxone. It was about 44% at 24 weeks compared to about more than 70% on methadone. Actually, the retention that we're seeing on buprenorphine naloxone is not less than what is seen typically in other studies. It tends to be around 50% at 6 months, which is not very positive news, because people who drop out of treatment, 90% or more tend to relapse. So it's key to keep people in treatment. The reason that there's a big difference here, or what we're really seeing, is better methadone retention than we typically see, because the programs that were doing this were very, very good opioid treatment programs. So what we did is we looked at their retention as a function of their dose of medication. And the percentages that you see there, so we're looking at groups on various doses. The numbers at the top are for methadone. The numbers at the bottom are milligrams of buprenorphine. And the percentages along the curves are the percentage of patients who fall into each of those dosing groups. And you can see that even up to relatively high doses, the treatment retention improves for both medications. And we see this steady trajectory of improving retention for buprenorphine up to 32 milligrams. Now, in this study, I didn't mention this yet, but in this study, there was no limit on the dose of methadone that could be given, but 32 milligrams was the maximum amount of buprenorphine that could be given, because that's actually the product package insert product label suggests that 24 milligrams is the maximum dose, but in the United States, we do tend to go up to 32 milligrams and tell practitioners that's the maximum. But the question that, and in the US, most practitioners believe that doses between 12 and 16 milligrams are adequate, and they have great concerns about, when they're treating someone in their office, about medication diversion if they go over 16 milligrams, yet we don't have adequate retention. So what these data tell me is that we may be underdosing many of our patients with buprenorphine, and we may even need to explore doses higher than 32 milligrams for some people, because we see this curve going up, and we don't know if we can do even better at higher doses. Also, these are very recent data that we're still working on, but we were able to discern 6 different induction trajectories. That is, in the first few days, how do we get people on buprenorphine? And they range from going very high very quickly. As you can see with the higher curve there, or for some reason, some people remained at a low dose. And the dropout in the first 7 days was significantly less on those who got the higher trajectory, getting people up to a high dose very quickly, and there was no increase in adverse events. So we need to look at the data more, but this is suggestive that we're not getting the medication doses up sufficiently quickly. We were able to do a qualitative study where we interviewed both patients and staff on various medications, because we wanted to understand why are the people dropping out of treatment. And there were specific reasons for buprenorphine naloxone that you see over on the left column. There were some reasons common to both groups, and there was the reason the methadone column is blank is that there was nothing that the methadone patient said that wasn't common to both groups. So with the buprenorphine, they talked about negative medication experiences. Many wanted to switch to methadone. They said that they wanted to feel the full effects of methadone, which, as you heard, is a full agonist compared to a partial agonist with buprenorphine. And then typical reasons for dropout, people continue using illicit drugs, they go to jail, they have a hard time getting to the clinic on a daily basis, or they don't want to keep taking medication. And here are just some quotes from some of the patients. I was hoping for the methadone. If I'd gotten that, I'd have stayed the whole 8 months. There's no doubt in my mind, but being that it worked so well as a blocker, in other words, this patient is saying when he took buprenorphine and he tried to use illicit opiates, he couldn't feel any effect from that, and he wanted to feel that effect. He wanted to be on methadone so he could be stabilized but get high whenever he wanted to. The buprenorphine didn't allow that. So to some extent, the very good efficacy of buprenorphine and the way it works may cause some people to drop out, which is an issue we'll have to address. And then a female patient, when I would take methadone, it would kind of give me energy. I guess I would say where the Suboxone didn't do that for me. Just a little bit of not really euphoric. I don't know how to explain the feeling, just made me feel good. So again, methadone as a full agonist is going to give some sense of high or euphoria, whereas buprenorphine as a partial agonist doesn't do that, and some patients may be seeking that feeling. Looking at the urine drug screens over time, we did see that during the first 10 weeks of the study, there was less opiate use with buprenorphine naloxone, and that probably is a function of dose, because this is the same curve looking at the doses of both medications. And because it takes several weeks, as was mentioned, to get up to a therapeutic dosage of methadone, during that early part of treatment, the patients on methadone may be using more opioids. And then with buprenorphine, as you saw, if we want to, we can get the dose up to a stable therapeutic dose within a couple of days, and so we can suppress the illicit opioid use early on. So I'm going to have to skip forward here because I'm out of time. So I just want to mention two more items. And we looked at HIV injection risk behavior, and that's been well studied with methadone, and methadone dramatically decreases that. It has not been previously so well studied for buprenorphine, what we're looking at is needle sharing in the prior 30 days among those who completed 24 weeks, and you can see the reduction from baseline to week 24, which is highly significant and worked with both medications. And this is people who are having multiple sexual partners in the prior 30 days. Again, we see a significant decrease with both medications, which suggests that buprenorphine is a very good HIV prevention. Then finally, in relationship to what Dr. Torrance said about genetic issues, and this is work that we did in collaboration with the geneticists at Dr. O'Brien's University of Pennsylvania, we were able to get DNA on about 800 of the participants in the study, and we thought that the mu opioid receptor gene, which is where these medications, we believe, exert most of their effect, would possibly be related to treatment outcomes, and we found no effect there. What we did, surprisingly, witness is that there were some effects of the delta opioid receptor gene. So this represents a single nucleotide polymorphism or a mutation in the intron or non-coding region of the gene that codes for the delta opioid receptor. And this finding was only in African Americans. You can see that was 77 individuals who we had DNA on. And so for people who had, so the left side of the screen is people being treated with buprenorphine, the right side is people being treated with methadone. And what we're looking at is the mean percent of positive tests in the last 8 weeks of the study. And what you can see is that the people who had this mutation, if they got buprenorphine, did much better in terms of illicit opioid use. Just the opposite with methadone. And this, again, is only African Americans. The people who had the mutation did worse with methadone. And you can see that's highly significant. So we don't know if this is some type of chance finding. We don't really know very much about what the delta opioid receptor does in opioid use disorder, or even how these medications interact with the delta opioid receptor. But this raises a lot of questions that should be studied further. And if our government shutdown ever ends, we hope we can apply for some funding to do a further study in African Americans. And there were some also intriguing findings with the delta receptor among European American females only with buprenorphine. And there are 2 other mutations also in non-coding regions of the delta opioid receptor gene that do predict outcome with buprenorphine. So a lot more needs to be done. This was a huge endeavor, as you can see by the numbers there and the number of blood draws we had to accomplish. So just to summarize finally, there were no differences detected in the liver effects of buprenorphine versus methadone, and no clear evidence of any serious liver injury. And the clinical advice I would give to people, practitioners using these medications and to patients, is there isn't any major worry about liver disease being caused by the medications, and we don't need to do a lot of unnecessary screening of indices of liver health. However, many of these patients do have underlying liver disease, and the clinician needs to attend to the underlying liver disease as the clinician would whether the patient was on these medications or not. Hepatitis and illicit drug use are the main drivers of increases in these liver enzymes. We showed that buprenorphine can be successfully integrated into the licensed, federally regulated opioid treatment setting. And we found worse treatment retention with buprenorphine versus methadone, but the higher the doses got, the better the retention was. So there's a lot of work to be done in improving our retention with this medication. And I'm out of time, so I'm going to skip ahead and just finish up. And I didn't talk about anything but the last bullet point, which suggests that there is the possibility of a relationship between mutations in the delta opioid receptor gene and medication response in some subgroups that deserve further exploration. And here is just a thank you to all the individuals, agencies, and programs that participated in this study. Thank you very much.
Merci. Merci. Peut-être une question, comme on est déjà un petit peu en retard. Sinon, oui. Micro.
Hi, I'm Patrizia Carrieri. First of all, I would like to thank you for this really fascinating trial. The results are really useful because you can't imagine in France how we are expecting results like this, because every committee I attend in hepatitis C patients, concerning hepatitis C patients, they ask about this question. This is the one major question, so thank you for doing this. The second, I have just a short question about, I don't remember whether some HIV-infected patients were included in the trial, whether there were people who have been exposed to previous antiretroviral agents which are associated with hepatotoxicity, and also whether you could control for coffee consumption, which is known to be associated also with better liver function. Elevated coffee consumption. Yeah, thank you.
I didn't mention any of the data about HIV infection because it was less than 5 patients in the entire study who were HIV positive, which again is a good testament to our prevention efforts, but once again, it's critical that we keep pushing ahead with those prevention efforts, because if we don't pay attention to it, they can decline and we can be in trouble again. But we couldn't say much about the HIV because we just didn't have that many people in the trial who had that.
Dernière question. Bon,
I should mention that the main outcome paper has already been published, so if anyone wants a copy of that, yes, and you can contact me through Jean-Pierre, and I can get you a copy of that, which will help that you can give that to the patients and practitioners here in France.
Oui, une question, je voulais savoir...
Merci beaucoup.
Oui, je voulais savoir sur un plan clinique, quand on a donc des patients sous buprenorphine avec des bilans hépatiques perturbés, qu'est-ce qu'il fallait faire? Est-ce qu'il faut surveiller simplement, baisser la dose du traitement, arrêter le traitement, changer de traitement?
It's important to remember that there could be rare effects that we're, even in this very large study, we're not seeing if it happens less than 1 in 1,000 times. But based on the results of the study, I don't think you need to take any special precautions with patients on buprenorphine who have hepatitis C other than to monitor their liver health exactly as you would for any other patient with hepatitis C. And ideally, I think we're going to be hearing about it later, but ideally, since the treatments for hepatitis C are now so much better than they were even a few years ago, and we can get 70 to 80% cure rates, get these patients into treatment for hepatitis C as soon as possible. But no special precautions other than following their liver disease as you normally would.